Welcome to IMIT Seminars. We created this space to help MSK specialists immediately impact their patients, businesses, and personal lives through relevant discussions and practical insights. Let's jump on in. Hey everybody, welcome to episode 2. This is Dr. Sean Flannagan. Today I'm talking with Mr. John Hobbs, the founder of the Hobbs Master Needling Series. Today, John and I are going to be discussing tendinopathies, specifically Achilles tendonitis, and those presentations and how we want to clinically reason our use of needling with these patients. John, first off, thanks for joining me today. I'm excited to connect with you this week.
Thanks, Sean. Thanks for inviting me again. It's always good to chat to somebody, anybody, especially you, but anybody.
Yeah, especially in this season of COVID. I haven't seen you in over, it's a year and a half now. So. Yeah. I'm excited for you to get out here in November. I'm excited about this topic because it comes up all the time in our foundational courses in DIN 1 and 2. And the thing with DIN 1 and 2 is it's all about needle safety. It's all about helping people feel confident with needling and just to increase their ability to just get a little bit of clinical reasoning. So I think taking our time to dive into this topic is going to help us, because it allows them to get past, the initial overwhelm of putting a needle into the body and being safe to now I need to clinically reason how to do this on a day in and day out basis. And I'm sure that's what you see in your foundation courses over there also.
Yeah, I mean, the big problem, or the big challenge I have, I suppose, is for me, when I've got new guys started with me, new PTs, I want to teach them about acupuncture and dry needling. One of the problems I've got is I want to teach them so many things, because being a clinician myself and being a clinician for the best part of 3 decades, I know the sort of things that they're seeing at work, and I know the questions they're asking, and I want to be able to answer those questions. And the problem comes with overwhelming them with information. One of the reasons why the DANS 1 and 2 are structured in the way they are is so we can build on that. The problem is that we can give too much information too quickly. It doesn't get processed, it doesn't get assimilated, and therefore you struggle with the clinical reasoning, because you've got to get your building blocks in to be able to create a foundation to go from. So yeah, it is a bit of a challenge at that level. I think for me, the thing that I want guys to grasp to start with, and we chatted about this a little while back on a previous episode, is think about those 5 reasons why we needle. I always come back to that. So check that out on that other video. But just to recap it while we're here chatting, we've got that local healing response, that local analgesia, the myofascial responses, the segmental analgesia and segmental responses, and the supraspinal central effects, which I talk about in more detail. We're going to come back to those, interestingly, when we're talking about tendinopathies. I think it's interesting that you mentioned, Achilles coming up a lot with the clinical groups that you're seeing, because I think it's a question I get asked about all the time. And the problem is, it isn't a simple kind of like yes or no. When people say, can you use it for an Achilles tendinopathy? I'm like, my answer is yes, because when we're looking at any kind of myofascial pain or dysfunction, the answer is always yes, you can use a needle. That's not really the question I say to guys they should be asking. What they should be asking is it the most effective modality at this point in time, with this pathology, in this environment, with this client, at this stage? And the answer to that might be no. So I think what we need to do to answer the question more specifically about tendinopathies, I think we need to think about going back to what the problem is, thinking about the physiology. So the first place I start with anything when I'm thinking about needling is, start with the subjective, so we get a really good history. So that's not about needling, that's just about good clinical treatment, good clinical practice. Get a really good subjective. From that, hopefully you'll get a really good objective. And then you can make some decisions on about what you actually think the problem is. And I'll give you an example. If you've been around long enough in the world of treatment, one thing that I've discovered is the smarter we get, the more vague we become. And what I mean by that is, years ago, it was all about it being a tendinitis. And then we decided some of them weren't itises. So it became an opathy, became a tendinopathy. And then I would even challenge the idea that in some cases there isn't an opathy there. There's an algia. We know there's pain there, but do we know if there's an actual pathology? And if there is a pathology, what's going on? And we make assumptions. I like to investigate as thoroughly as possible. So good subjective, good objective, and then even things like point of care or diagnostic ultrasound, and have a look at the tissues and see what's going on, and add that layer of investigation into what you're doing as well. And so we end up coming up with a decision about what the problem is. And what I say to guys when they say to me, "What would you do for a tendinopathy?" I go, "Well, what sort of tendinopathy is it, or what sort of problem do you think it is? What's the state of the tissue?" Because that's going to be the determining factor on how you needle this. And it could be an Achilles, or we could be talking about a lateral elbow as well. It isn't just about an Achilles, but obviously the loading is a little bit different in the areas. But when we look at that, it's like, okay, well, what's going on with that? So I generally have, when it comes to needling, four things that we need to consider if we're needling for tendinopathy. So we need to think about the central effect, which is how painful is this problem? What's the sort of presentation? They're coming to us and they're saying, is this a problem all the time? Is it a problem under certain circumstances? Are they aware of it in certain loading episodes, or is it just something that's there all the time? What's the history? How does it present? Again, when somebody asks me about a problem, can you treat this or that? Or they say to me, "Oh, my client's got a tendinopathy, what should I do?" My next question is, well, how does it present? Because just saying the diagnosis doesn't really tell you how you're going to interact with that intervention. You need to get a little bit deeper into it, which I know is a bit of a challenge, but ideally that's what you need to do to make good decisions. So I think about what's the central effect. So we've got 4 ways we can needle. We think about the central mechanism, and that's going to be about the state of tissue generally, the pain and discomfort that person's got going on, and any other central effects you want to affect, autonomic effects and so on, state of healing, inflammation, general pain, those things. And then we break it down, and we've got the loading tissue. So this is what I often talk about, the difference between the loading and the loaded tissue. The reason being is, when I look at these semi-standard protocols, and we've chatted about this before, haven't we, when we see some needling interventions or needling courses, and everything is laid out as a protocol. Achilles, here's what you do. Tennis elbow, here's what you do. And that's great, and that's useful. And we do that as well. But my question then is, with some of these, when people say to me, "Oh, well, when I treat a tendinopathy, what I like to do is I like to needle into the tendon, or I like to needle at the attachment." And I'll say, okay, how is that going to, if it's going to work, how is it going to work? Well, if it's going to work, it's going to work because of that reason number one, the local inflammatory and healing response that occurs in that area. And so that's great. But what happens if there's no pathology in that tissue? What happens if that's radiculopathic? What happens if that's caused not by the loaded tissue, but by the loading tissue? What if the pain is referred from elsewhere? What if that's about, say, gastrocs or soleus generating that pain presentation? Or what if it's about tib post, giving you that pain referral to the Achilles region? What if it's about that? Needling in the local area will have no or limited effect, because for something to be effective, the pathophysiology has to match the mechanism. So problem is with protocols is when somebody says, "I've got an Achilles problem," "Oh, well, here's the protocol," and you apply it. But that doesn't necessarily mean that because you've got an Achilles problem, everyone's got the same history or pathological presentation. There are certain different types of presentation to that tissue. So it has to be appropriate. So I think about central effects. I think about the loading and the loaded tissue. So the loading tissue will be the tissue loading upon the connective tissue where the symptoms are being generated or presented, in fact. So that could be gastrocs, it could be soleus, it could be any of the other structures around there. It could be the sole of the foot as well. It could be quadratus plantae or or so on, because of the relationship between, you know, the Achilles and then down into the connective tissue under the heel. If you look at that continuation of that tissue, that connective tissue, towards the plantar fascia and so on. So we've got the loading and the loaded tissue. Now, the loading tissue, needling that, is going to offload the loaded tissue. So the loading needling is more for that myofascial effect. You know, you could think of it traditionally like a sort of trigger point effect, although you don't have to be traditionally as aggressive with that needling. You could just put a needle in there and leave it and see what it does to that tissue. So we've got the loading tissue. And then we've got the loaded tissue. Now, if the loaded tissue is pathological, then we're asking ourselves, well, what state of pathology is that at? You know, do we want to bring an increase in circulation into that area? Is it very chronic? Do we want to try and break that chronic cycle with an acute stimulus? Do we want to use it that way? And then the fourth thing that I would consider is, as you always do, is the spinal segment. What segment is driving that mechanism? You know, is this a bottom-up problem or is it a top-down problem? So by that I mean, if you've got an Achilles problem, is this due to foot position and foot mechanics? And I know a lot of people think that I'm going to drive everything towards a needle agenda, but I should probably perhaps tell people that previously, not only was I head of a school of physical therapy, where obviously we look at all interventions and we look at the research behind that. Previously, I was also head of MSc in clinical biomechanics. So I'll still come at things from a biomechanical perspective, but I try and keep an open mind. As we always talk about, you know, sign of intelligence, the ability to entertain an idea without accepting it. So keep an open mind when you're thinking about tendinopathies and loading, and is this a bottom up or a top down problem? And what I mean by that is this driven by the reaction force from the ground, what's going on with the forefoot perhaps, or the calcaneus, or how that loads through the lower limb, or is this anything to do with what's happening from above and control in that area? Is this about innovation to those structures? Is this about the stability of those structures relative to how they're being controlled by the dynamic features there, which would be with the muscles in that area? So I'll always have a look at the spinal segment, and probably a little bit unusual for some needling, but something I use very much clinically is going quite deep into those structures in the spine to have a look at what's going on mechanically. And I use the needle diagnostically in that sense to palpate and see where there's dysfunction deep in. It's a little bit like IMS, intramuscular stimulation, Changun style. Not the same, a little bit different, but you know, there are similarities between those systems. But I think it's very much our own approach into that, as opposed to being the same as that. You know, I've worked with sort of IMS practitioners before, and I see some similarities, some crossover, because anatomy is anatomy and physiology is physiology, but we have a slightly different approach with the with our dynamic integrative needling system. It's bringing it together in a slightly different way. So I'm thinking about that spinal segment, and the spinal segment can be diagnostic as well as therapeutic in this scenario, because whilst needling locally, there will always tend to be a problem. The one area where you can pretty much guarantee you'll get a reaction is the loading tissue. So regardless of whether the loaded tissue is dysfunctional or not, the loading tissue pretty much will always be, because if the loaded tissue isn't, the loading tissue is creating a problem. If the loaded tissue is problematic, the loading tissue will be problematic as well. And then it's interesting to look at what's happening with the spinal segment, because if that is problematic, then the question is this a driver of the problem or is it reactive to the problem? You know, it becomes a little bit like chicken and egg, you know, which came first. The issue is that it becomes academically a fairly moot question, because now you're in the thick of it and perhaps you've got both, the local effect and the segmental effect. So it becomes almost academic to argue which one came first, but now they're both present. I feel that you need to address both components. If you don't, what tends to happen is you can have a very prolonged treatment process with that tendinopathy. And one of the things that, I think the goal of any clinician is to expedite that problem as soon as possible, and to deal with that as soon as possible. And if there's one little tip I could give guys with needling, just take a look at that spinal segment, see what's going on, and it isn't just palpate it by hand, palpate it with a needle. If you don't know how to do that, I recommend that you don't do that unless someone's showing you how to do it, because we are exploring those tissues at a greater depth than traditionally you would perhaps needle them. And there are elements of risk, obviously, always, if you don't know where you're going. I mean, we do cover that. We cover some deep needling in the 1 and 2 courses, but I really explore those. When I get into the sports course, which is like a level 3 course, as you know, Sean, I get a little bit more into this, and I show you how to put these protocols together yourself. Because although I said we don't do a lot with standardized protocols, we have standardized concepts which inform the protocols. And what I teach guys how to do is how to create those protocols for themselves, given the conditions that they're seeing, because you will see different types of tendinopathy and tendinopathic presentations, or even tendinalgias, if I use that as a more overreaching term. One of the things that I find quite interesting when we get down into the anatomy of these structures, and that's worth looking at, is when we do things like ultrasound the Achilles, and you can see how the gastroc actually feeds into that tissue. And I know that when I chat to some clinicians, they have this expectation to attach like this, but there's more of an attachment kind of like this going on, where the tissue is feeding into it, and the Achilles becomes more of a ponerosis between the gastrocs and the soleus. So that interaction starts to become very interesting. And again, when you're having moving up from the Achilles, but when you're moving into the calf and soleus, and you've got soft tissue injuries in there which you believe are purely muscular, sometimes it's interesting to get some needles in and around those as well, because you'll actually find that it will be in the connective tissue between those as well. And that's why sometimes you think your client may re-injure, and actually they just haven't resolved in the first place, because from a muscle perspective they may be okay, but sometimes it's more about that connective tissue in between, and understanding that. And needling can help you with that as well, because it allows you to get down into that tissue a little bit deeper and explore that, and it becomes a little bit more diagnostic. So I suppose for me, if I'm dealing with Achilles tendinopathy, I'm thinking about those 4 things. I'm thinking about loaded tissue, spinal segment, but also not forgetting central. Now, one of the reasons I would use central as well is not just for the presentation that we're treating. It's also sometimes, if the spinal segment is problematic, it's often uncomfortable on needling. And so I'll utilize central needling to create a descending opioid effect, an analgesic response that can lessen the discomfort of treatment as well. If needling the spinal segment isn't uncomfortable, that's probably not your problem. When the spine is, when the paraspinals are very dysfunctional, they can be quite tight, quite reactive, quite uncomfortable. And so we'll needle different areas in different ways as well. One of the things I find quite often is when clinicians needle, they have one style of needling. So they have a modality in surgical pathology. But when you're needling different structures for different reasons, perhaps in the same presentation, you need to needle them in different ways, because you're trying to elicit different responses from that tissue, because there's slightly different things going on. It's all under the same umbrella diagnosis, but there's different physiological and mechanical things going on throughout that system. And so we're addressing those differently. And we're thinking of the needling like we would exercise, where if you were treating a problem that was changing or progressing, you would change your exercise based on the rehabilitation of progression. And that's what we need to do with needling in these scenarios. So I don't know whether that makes any sense from a theoretical perspective. It would certainly make sense if I could show you that, and I'll show you what I do, and you'd look at that and go, what are you doing now? And I'm like, well, that's why I'm doing that. And you're like, does that make sense? Makes sense. It's very mechanical. The local, The local needling is all about the physiology and the healing and creating that afferent stimulus to change that chronic pain sensation, but also the either the chronic state of the tissue and creating a new acute inflammatory response in that. The muscular is obviously for the myofascial effect, and that's the loading needling, but that will also have a segmental effect on that area as well. And then we've got the spinal segment, which is segmental analgesic from an analgesic perspective, but it's also mechanical, and it's the mechanical dysfunction of the spine as it affects the myotone, which is a very interesting idea. And all I'll say about that when people get a little bit bent out of shape about it is just entertain the idea. Don't need to accept it, just entertain it. And then perhaps give me the opportunity to demonstrate it to you and show you how it works and why it works and how you can integrate this into your clinical practice. And once you have, I find that people don't have a problem accepting it. Once they can see that it does something. Sometimes it just doesn't make a lot of sense when you look at some of the literature. If you look at others, it does. But I certainly find from a clinical perspective, it makes a huge amount of sense to me. And that I introduced into my game many years ago when I was confronted with a lot of tendinopathies. I was working in my own clinic, but I was adjacent to a very, very well-known factory in the UK. And if anyone listens to this in the UK, the factory is called Mr. Kipling's, and it makes cakes. And they have a very, very famous tagline in their advertising. And every time I say this when I'm teaching Mr. Kipling's, what I get back is the tagline. I'm not going to bore you with it now, but it is. So they have a lot of guys doing very repetitive tasks. 12 hours a day, 4 days on, 4 days off. They repeat the same tasks. And some of those guys have been in that factory for 40 years, repeating those tasks. So I see a lot of very chronic presentations, a lot of very chronic tendinopathic or tendinalgic type problems. And so with the pressure to return those guys back to work in a functional way, with the limited skill set that perhaps some of the staff have and their opportunities outside of that factory is a good employer. Real challenges for those guys to get them better. I found that it put my skills in a test-retest situation very quickly. So rather than just being theoretically good at something, I had to be practically good at it, in a real sense that I had X amount of treatments, normally 4 to 6 treatments, to take this person who got a chronic tendinopathic presentation and address that before they were sent away for either injection or surgery. And we know how variable those outcomes can be with tendinopathic presentations. And even if they are successful, there can be a long term of rest and rehabilitation after them, which the employer wouldn't entertain. So I found that I had to explore avenues, and doing that from an anatomically driven basis, I started to introduce spinal needling and get deeper and deeper with that till I started to rationalize what was going on with that. And then looking at other work, again, people like Chan Gon and other guys, you start to see some perhaps some published evidence that supports those mechanisms as well, from a mechanical sense and not only a physiological sense. So I think it can be a challenge when you first hear it, but all I would say to you, if you're a clinician, is entertain the idea. I understand if you're a pure academic, you may struggle with those ideas, but my job is not to convince academics. My job is to upskill clinicians, to develop Monday morning techniques to deal with N=1 problems for those clients who are not changing. How do we solve those problems? That's my remit really, and that comes from a practical base of exploring those. So I know from my own experience, I need to at least consider those layers with the tendinopathic presentation. It isn't just as simple as, oh, where do you put the needles around the tendon? I can show you that in 2 minutes, and that's fine. And that will work for a certain percentage, but it's almost like a Russian roulette. You're almost spinning the barrel and just hoping that that's the pathology. So you've got your standard protocol and you throw it at everything that looks like a tendinopathy, and maybe you get a 60% success rate. Well, maybe that's happening because only 6 out of 10 times that was the right pathology. The other, like 4 out of 10, it was a different driver. And if it's a different driver, it's a different pathophysiology, it's going to require a different modality intervention. It can still be needling, because I needle pretty much everybody, not in an effort to put needles in people, but I find it's the quickest way for me to get to A to B. And as a clinician, my job is to get that patient from A to B as efficiently, as effectively, as painlessly, as pleasantly as well as possible. It's a paying customer. As pleasantly as possible, and to get them the outcome that they want. And so when I talk about these things, yeah, it takes a little bit longer. I know some people would like me just to drop a prescription out there for them and say, here's what you need to do, here's the magic pill. You know, yeah, what I want to be is I want to be genuine and honest with guys, and yeah, I can give you a prescription and walk away and leave you with it, but it isn't going to solve all your problems. I'm trying to help you solve as many of these problems as possible. And when they're outside of those standard protocols, the problem I had when I first started needling, I actually been needling for like 20 plus years, but almost 20 years ago, I walked away from needling completely because it wasn't solving my problems. And it wasn't until I came back to it and thought about it a different way and started to explore needling in a different way. And that's what's built the foundations of the Master Series and the dynamic integrated needling system, is that I needed to come up with more practical ways of solving problems. And I wasn't taught those. I was taught a very prescriptive standard way, and I found myself have to move out of that. My goal with the guys that I work with now is I don't want everyone to waste 20 years to get to where I am. You know, some people say to me, oh, you know, will it take me 20 years to get where you are? Well, no, hopefully I can give it you in a couple of years. Not a couple of years of training, but a couple of years of your experience, plus the training I can give you, I can get you there a hell of a lot quicker. I wish someone was teaching what I'm teaching when I was learning, because I feel like, honestly, I don't think I wasted time, but there's a lot of time digging, if you know what I mean. It's like archaeology. I spent a lot of time digging to show you the treasure. You'd rather just go to the museum and look at the treasure. You know, that's a very long answer to a short question about tendinopathies, isn't it?
Yeah, no, that kind of rings true with just my experience. Like, after going a lot through the different organizations here in the States, there was this protocol driven mindset. So I found myself falling for the ease of putting prescriptions and then treating with that prescription versus the person in front of me and actually clinically reasoning through. So this is how you did carpal tunnel, and this is how you did cervical headaches, and this is how you did tendinitis. And it was just, they were given these large prescriptive treating of conditions versus the person in front of you. And I love how you're saying we're going to use needling both as a almost in a differential diagnosis type of
definitely.
Scenario with the low back and everything, and then looking at these loading and loaded tissues and treating those. So when you get down to that loaded tissue, we know that's kind of our problem. How do you differentiate between doing like a peritendinal type of approach versus going into the tendon? And do you ever see yourself or seen any success with almost doing a fenestrating? Like, I know some of the medical literature, well, they'll go in and maybe pass through a tendon through ultrasound guidance like 20 to 50 times to recreate that healing response. They're using a hypodermic needle and something much larger, and they usually put them in a boot. But can we recreate that in our scenarios with the needles that we're using?
Yeah, it's an interesting question. You know, I mean, I'll always reference that notion that the optimum dose is the minimum required to get the desired result. If I can avoid putting a needle through a tendon, I will, because I don't feel, for two reasons. It's the same with scar tissue. You know, people say to me, can you needle scar tissue? Yes, you can. And I've got some work coming out on scar tissue. But yeah, of course you can needle scar tissue, but I advise people, if you don't want to needle it, don't, for two reasons. One, it's hard work for you. Two, it's uncomfortable for the patient. If you want to needle it because you have a clinical reasoning behind why you're doing it, absolutely, that's great. But if it's just there and you're needling it, then I would avoid it. And I would say the same about tendons. They're not pleasant to needle. They're very uncomfortable and they're hard work. It takes some effort to get a needle through, through a tendon, through the Achilles tendon. The main approach that I would use, if I feel that the tissue is problematic, I will needle peritendinally. So the needle will be touching the tendon, but it's not going through it. And I would use what's classically referred to as like a herringbone technique, where I'll needle adjacent to the Achilles and then along the middle of the Achilles as well. So you'll essentially be looking at 3 diagonal rows, which look like the ribs and the spine of a fish, hence the herringbone. And that would be my local needling for that. But the other thing I would perhaps say about that is when we get to things like injecting and putting the needle through, one of the things I find when we look at the research for any of these things, where we look at injecting, I'll often sort of consider, well, what was the dry needling arm of the trial? What did that show? And quite often there aren't dry needling the arms in some of those trials. And then if we track back to the 1940s, when we look at Travell and Simons, and we look at the evidence between injecting and just dry needling, and we can see there's like crossover effect in some instances. Is it the solution? Is it the mechanical needle creating the intervention? And of course, when we're talking about putting that needle through a tendon, we've obviously got that mechanical disruption of the needle doing that. But I also think, are there subtler ways of doing that if you're addressing the other components as well? So the difference with probably putting the needle through is that if that's going to be the intervention, it's going to be directly to that tissue. They put the needle through, and then, like you say, that tissue will be rested for a while it responds to that. Yes, of course, you could escalate to that, but I wouldn't escalate to that until I'd addressed all those other components that I talked about before. And if you are ever considering escalating to those points, or even injecting is an escalation of intervention, and you haven't needled in those 4 ways, I'll consider that you've probably escalated too soon to that point. If you've exhausted those 4 mechanisms and you've really investigated that spinal segment, and here's where I can't emphasize it enough, that has to be done in the right way. It isn't, I put a needle next to the spine, it didn't solve it. You've got to understand how that's being used and what you're attempting to do in that area. It's more than just putting a needle in, say, multifidus or longissimus and just waiting for it to do something, or doing a little bit of trigger point needling. That's not what it is. A little bit different. So if I haven't cleared that spinal segment, I wouldn't progress somebody to a more, I don't want to say aggressive intervention, I think that's the wrong word, but I suppose a more significantly penetrative intervention before then. So for me, no, I don't, because what I'll find is I can resolve the problems without escalating to that point in most cases. But again, I think it's important before you escalate to something like that is to really understand the pathology and get down and, get deeper investigation on it if need be, get some scans on there and really try and identify what's going on. But of course, what you're going to remember is the scan itself is still only a snapshot in time. It shows you that there's something pathological with that tissue, but it doesn't tell you that that is the problem, because in some cases that can be incidental to the pain of the presentation anyway. And I think, again, that's something you need to keep in mind, which is why even if I see something on a scan, I'm still not necessarily going to want to plunge deep into that tissue if I can do it more superficially. Because if I can do it on a layered effect more superficially, then I can rehabilitate that client sooner. It's not that I'm bothered about going into that tissue. It's just that if we can manage this more superficially and more completely, because something is very rarely one tissue, is it? If we think about it, if we've got an Achilles problem and we're just hammering the Achilles, yeah, but why have we got this Achilles problem? Is it top down? Is it bottom up? It's got to be an element of one or the other, or a combination of the two. So what else do we need to address there? If it's a localized injury, if something has happened to that tissue, fair enough, that's a localized injury. But in the world of a biomechanical dysfunction or a myofascial dysfunction, it's never going to be about one thing, one tissue. So again, another long answer, but I mean, you could needle if you were going to needle through a tendon. And the one thing that kind of makes me hesitant about this is perhaps the level of discomfort that generates. And I'm thinking about my client all the time. And remember those things I always say: respect the patient, respect the anatomy, respect the tendon. Just because putting a needle through the tendon, perhaps in the long run, works towards resolving the problem, doesn't mean it's the way to go to resolve the problem. You know, I would always think about, well, how do we respect the patient? How do we make this journey as effective and palatable as possible as well? You know, once we get into certain situations, I know we can be less conservative, but I think on a whole, address those mechanisms. The reason being, I've seen plenty of people who present with what looks like swelling, thickening of the tissue, the tender on palpation. So in all intents and purposes, they've got a reactive state in that tissue. And then I'll needle the spinal segment and we'll come back and they're not tender. And so you look at that and you think, okay, well, that's one of two things then. Either needling is magic, or that's not the pathology I thought it was. I'd like it to be magic, and then that would make me like Dumbledore, someone like that, and that'd be pretty awesome. But it's going to be about the pathological presentation, and it's actually something else. And that's where it can be interesting, because it can be diagnostic. The issue being that, I suppose, from an orthopedic sense, when you see that pathology, that presentation in the Achilles, you're going to go straight to the Achilles, or at least the foot. And I think let's look at everything that interacts on that first. It's not going to take you long. It'll take you a couple of minutes. So there's no excuse for it slowing down the process, and it can actually speed the process along. Something that I hear sometimes, guys say to me, oh, I don't needle because it takes time. I needle because it takes me less time. That's why I do it. I'm pretty lazy. So if I can get there quicker, I'm gonna. And this is one of the things, and this is why I don't get into arguments with guys who are very anti-needling. I don't get into arguments with them. One of the reasons being is because I've been doing it for 20 plus years. That's 50,000 treatments. If they want to argue that needling's no good, I'm like, yeah, whatever, fine. But you know, I use it every day at work. I've not used it, and I've used it, and I've gone between, and I know which works quicker, which is why I do it. You know, I don't have shares in a needling company or anything, you know. It works quicker. So when guys want to argue, I'm like, yeah, fair enough. Yeah, you go for it, fella. You ignore it all you want. It makes no difference to me. Because all that's going to happen is I'm going to get to these solutions quicker. And that's great for me, you know, and great for my patients. And that's all I share with those that I teach, if you're interested in hearing about it. If you're not, I don't need to convert you. It's fine. Just going to entertain the idea. And this is what I say about the spinal needling, because even guys who needle, the spinal needling troubles them. And then what happens is they come on a course and I demonstrate it. And some people are like, oh, that's quite deep. Yeah, understand your anatomy. This is where it starts. Technique is informed by anatomy. Don't go out and learn bunches of techniques. Understand anatomy. Understand the physiological mechanism and the location of the anatomy. Once you understand that, that will inform the technique and why the technique is what it is. And then when you perform the technique, and I do this on courses, when you know, I'll have a model up and I'll needle them, and they'll get off the bed and they'll look at their neck range of movement or lumbar spine, and straight away they'll be like, my range of movement's gone up. Yeah, well, now that's gone up without me doing anything to you, not mobilized, not manipped, needled, just take it out. There's a change in that function. Well, now we've got an opportunity. We've got to change the state of that tissue, what's going on. So we can change not only what happens to that tissue, but what happens to that segment, because now we've got changes. And the reason we had dysfunctions before was because of what was happening myofascially in that area. But if you've got myofascial dysfunctions in that area relative to how that spinal segment moves, that's going to influence the innervation from that spinal segment, because everything is related and everything in the central nervous system is related. Nothing happens in isolation. As much as we would like it to, I've got a post coming out about that soon. Everything is interrelated. You know, I do some cadaveric anatomy teaching, and I was speak with anatomists. We have this comment all the time. They're like, everything is interrelated, absolutely everything. You know, you get a nice anatomy textbook where everything's laid out for you, or a nice app where it's all lovely and laid out, and they all look like that. Everything looks separate. And then what happens is, when you actually look at it, it's all kind of like that, all kind of bound together, and that's what it really looks like, and that's what it does. So central nervous system knows everything. Spinal segment will be related to what's going on at that region, as well as what's going down at the end of that, dermatomally and myotomally. So got to look at those segments before you start pressing through that connective tissue hard into the tendon. But of course, if those other systems fail, by all means you can progress on, because we have to look for a solution. But the escalation should be moderate and appropriate. One of the things that a colleague of mine spoke about some years ago in the world of professional sport, he worked in Premiership football in the UK, Premiership soccer. And he said, one of the big problems that we have from a musculoskeletal sense, particularly in sport, is it becomes an arms race. How fast does it escalate from here's your injury to injection surgery, and more invasive procedures, without a respect for the tissue? You know, one of the things I always say about needling, which is why we come back to this idea of the minimum dose, or the optimum dose is the minimum required to get the desired result. What we need to do is whisper to the cells, not shout at them. They know how to get better. What they need quite often in those chronic states is a little bit of acute facilitation to re-stimulate them. They want to heal. It's what they want to do. So we need to stimulate that gently. Yes, of course, if we need to start going through the tissue and disrupting it more, we're much further down the line at that point. And it's okay to do that, but we need to make sure that that's how far down the line we are first before we do. That's my only hesitation with those techniques, is if I start teaching those on some courses, I know that people are going to reach for that straight away. And I think I don't mind talking about those much later on, when guys have got a really good standing and a really, really good foundation of understanding needling. Not that they know a bunch of techniques, because I know on the surface that's what it looks like, but it isn't about that. It's about understanding what the technique's about, you know, to understand what's underneath the hood, really. And then yes, of course, we can we can utilize those more penetrative techniques. Does that make sense?
Yeah, no, that's it's brilliant, because it's always the what's feeding into the system that caused the pain to come in the first place. You know, we tend to treat the pain, and I like the adage or the saying that pain is the last symptom to show up and the first to leave. Like, there was things going on mechanically and repetitive and different things that feed into the system, and then pain showed up. We treat the pain leaves, and if we're not really treating the causes or the things that are loading into that area or contributing to it, or it could be even behavior related with that certain patient, then we kind of fail them in the long run. We can get rid of the pain real quick, but then if we don't change their beliefs or their understanding of how healing happens, or how the body reacts, or how they need to load differently, then we're never going to change how they think, speak, and act around their future, and then they're going to be right back into us. So I think that's a brilliant way to kind of look at it, and to really progress slowly as you get more aggressive with your needling. Make sure that you've taken the time to differentially diagnose and strategically gone through what's the driver and what's loading into this tissue and what do we need to change. So I think that's brilliant. And I think
one of the things I would add to that off the back of your comment then is, and this is going to sound strange, because everybody assumes that, particularly in the UK, everyone assumes that acupuncture is about pain. And one of the things I'll say, particularly when I'm like on the sports course and when I'm getting deeper into the tissues, is I say the outcome I'm looking for, I'm not, and you've got to understand this, you've got to take this in context, right? I'm not looking for a change in pain. I'm looking for a change in function. Pain will improve. If the function improves, the pain will improve, because pain's a symptom. That's all it is. And it's just what that person's talking about. I talk about this, I have a background in mental health. And one of the things I would say about mental health, and I talk about this on some of the more advanced courses when we do like sort of master classes later on, when we talk about things like addiction and mental health, and how we can use parasympathetic stimuli of needling to help with these things as well. one of the things I say is that what happens is too many people concentrate on the smoke. The house is on fire, they're concentrating on smoke, and what you need to concentrate on is why is the house on fire? And that's the key thing, really. And that's the same with pain. Pain is the smoke. Why is the house on fire? You need to get a little bit deeper and have a look at that, and not worry about that smoke. It's there, it's telling you can see it from a distance. You see the house on fire from a distance, but when you get up close, don't be worrying about the smoke. You need to deal with what's going on inside. And I think the issue with that, with needling, is I'm looking for changes in function. I'm looking for improvements towards exercise. I'm always driving the needling in a route towards improving strength, movement, function, confidence, and layering that with education. It's not as passive as people would believe, particularly when you're discussing and educating the client whilst you're needling them. That's got a very kind of limbic system role as well in there. So yeah, completely agree with you on that respect.
So many layers for us to get into. I'm looking forward to talking more in the future and seeing you over here in November. So let's kind of wrap up, and we'll jump into this next week or the week after and keep going.
Yeah. Okay, Sean. Thanks for your time, man. Cheers.
All right. Thanks, John.
Thanks.
As we're wrapping up here, hey, go to our website, imetseminars.com. Check out our dates and locations. John is going to be with us the first 3 weekends in November. Sorry about that. The first weekend he will be teaching, it's a Saturday, Sunday course. He will be teaching in Atlanta, Georgia, the Pelvic Health Management course. This is a brilliant course. It's both for people that treat men and women's pelvic floor conditions. It's not really a MSK trigger point model type of system. This is about the management of like IBS, nutrition, digestion, and like overactive bladder, erectile dysfunction, referred pain, neuralgias, and different things. It's really a management course, which makes it so different from anything else here in the United States, just based on John's extensive experience and history. He brings in all these different tools, and it's a game changer if you are involved with men or women's pelvic health management. So he'll be doing that the first weekend in November. The third weekend in November is he'll be doing that same course, Pelvic Health Management, in Phoenix, Arizona. So if you can get to either one of those again, our Saturday, Sundays are all of our DIN3 courses. And the second week of November, he will be in Phoenix teaching the Advanced DIN for Sports, Injury, Recovery, and Performance. This course is just brilliant. He goes into parasympathetic, sympathetic input, just like he kind of does in the pelvic health course. But how to utilize this for recovery, and how to utilize this for performance, and how to influence the proprioceptive system and recovery and the vagus nerve and so many different things. It's just a brilliant course about sports management. And so if you deal with athletes, circadian rhythm management and travel and different things, it's just a brilliant course. So that again is Saturday, Sunday, second week of November here in Phoenix, and you can check those out. They'll be also coming next year. If you want to get into the DINS system of the Hobbs Master Needling Series, we have a couple offerings towards the end of the year here. Our DIN1 will be in Atlanta, Georgia, November 19th through 22nd, and then again in Phoenix in December 17th through 19th. And then we have DIN2, our electric and perineural courses. These two courses are very different. DIN1 is kind of the manual aspects, full body approach. So you can take this course and never take another course from us, and you'll be able to treat 70% of the people that come into your clinic. And so DIN1 is more of a manual approach, more of an MSK approach, looking at each of the individual muscles, where DIN2 is more of a chronic pain, electrical, perineural approach. Again, full body. You can take this course. You don't have to take them in order. You can take this course, treat 70% of the patients, and never take a course from us again if you didn't want to. But very different approaches within these two courses. We have that one in Atlanta, Georgia, actually this coming up weekend, October 22nd through 23rd, and then again in November 5th through 6th here in Phoenix. So check those out. We hope to see you in a future class, and take care, and check us out at imetseminars.com. Take care.